sure there was data that necessarily surprised me. We reviewed a lot of the data from ESMO, which was just happened about 2 weeks ago. The data is incredibly impressive. So we've seen, dramatic benefit for giving enfortumab, vedotin, and pembrolizumab together in the frontline setting, as well as for giving cisplatin, gemcitabine, and nivolumab. We also talked about earlier approaches to non-muscle invasive bladder cancer, where we're really seeing like a pretty dramatic explosion of new therapies, the TAR-200 pretzel, the drug-eluting pretzel, as well as recombinant viral therapies for non-muscle invasive disease. So really, there's a lot already presented, a lot out there, and it's really just exciting to see it all. So, there were two big studies, CheckMate 901 and EV302, that both looked at frontline bladder cancer patients. I think CheckMate 901, in my view, we had earlier data from Keynote 361 as well as Invigor 130, which both suggested that combining cisplatin, gemcitabine, and a checkpoint inhibitor would be beneficial. And I think we were all eagerly awaiting to see what 901 would look like. And in fact, we saw that there was a clear benefit from 901. So I don't know if it was necessarily surprising. The benefit was there, it was real, it was better overall survival. The median wasn't that dramatically different, it was a few months difference. What was impressive from 901 was that for the patients who experienced a complete response, which was about 20% of the population, the median duration of response was 37 months, which to me suggests that a lot of the patients who are getting into complete response when you give these three drugs together are really generating these like long-term durable responses. One of the questions was posed, are we curing patients with metastatic bladder cancer? And actually the panel was really kind of hedging on whether we're curing patients. I like to think we are curing some patients. Just anecdotally in my practice, I have patients who are 7 or 8 years out now from getting a checkpoint inhibitor alone, and they haven't recurred. And I think they're very likely to be cured. I think we're all hesitant to use that term just because it's very hard to prove. But I do think we're making incredible headway in urothelial cancer. It's a great question. There's a lot of trials happening. I think EV-Pembro is really now the regimen to beat. And I don't think it's necessarily a competition so much as what can we add to EV and Pembro in the front line? Can we add other immune modifying agents? Can we add other antibody drug conjugates or other therapies that might sort of have a synergistic effect that might generate more long-term durable responses? As I look at EV302, I think that there's sort of two important points. There's the fact that patients are living longer when they get this regimen, but when we look at the PFS curves, there are many patients who are experiencing these long-term durable responses. It's like 30 or 40% of patients get EV-Pembro, may stop therapy and still respond to therapy, even after treatment stopped, sometimes for months or even years. And so what I'd love to see is that PFS curve continue to come up, go above 50%, because that's probably, that's at least our way of getting to a cure in bladder cancer. And I think to be able to do it with just one regimen, one frontline regimen that's given for a proscribed period of time and then stopped, to generate long-term durable responses, like that's super exciting, and that's really what we need in the field.